It really is quite something how common endovascular procedures are now. You hear about them all the time.
Millions a year, yeah.
And they seem, safer, less invasive. But like any medical procedure, there's always another side to the story, right? Potential complications.
Exactly. And that's what we're diving into today, the local complications, things that can happen right there during or after the procedure.
It's really essential stuff to understand, especially for you, our listener, if you want that deeper knowledge without getting lost in jargon.
Precisely. Because even though these techniques are revolutionary, a full understanding means knowing the potential downsides, too, the challenges that can pop up.
Absolutely. And our guide for this is going to be Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition. We're digging into the chapter specifically on these local endovascular complications.
Yeah, using that as our framework, our mission really is to unpack the most common, the most significant local issues.
Look at what causes them, how they show up.
And crucially, how vascular specialists manage them. We want to give you that clear, structured picture, those sort of aha moments.
And do it efficiently, respecting your time. Okay, so let's start at the beginning. The access site. The groin is common, right?
Yep.
And groin hematomas?
Very common. Probably the most frequent complication with percutaneous access.
How does that actually look? Is it just bruising?
It can be swelling, bruising, ecchymosis, pain right there.
Mm-hmm.
But it can be more serious, too. Sometimes bleeding is obvious. Sometimes it causes nerve issues, like neuropathy.
Like pain or weakness in the leg.
Exactly. Or even anemia if enough blood is lost. Maybe low blood pressure hypotension in really significant cases.
So what's behind it? Just poking the artery?
Well, it's often more complex. Maybe access was difficult, multiple attempts were needed, or the closure afterwards wasn't quite right, maybe not enough compression. Sometimes the needle goes through the back wall of the artery, or blood leaks around the sheath itself.
Okay. What about using ultrasound? I hear that helps guide the needle. Does that reduce hematomas?
Oh, definitely. Routine ultrasound guidance is a big help, especially for patients who are older or obese, or when we need to use those larger sheaths, say bigger than 6 French.
Right.
Studies show it clearly reduces the overall rate of hematomas, and specifically the moderate or major ones. You can see exactly where you're going.
Makes sense. So if someone does get a groin hematoma, what's the plan? Just watch it.
For smaller ones, often yes. Observation, maybe correct any clotting problems if they're on blood thinners, sometimes transfusion if the blood count drops.
Okay.
But if it's bigger or actively bleeding, manual compression is key. Sometimes mechanical devices, too, like a femostop or C-clamp.
And imaging.
Yeah, we might get a CT scan to see how big it really is, or if it's extending somewhere else, like the retroperitoneum. And duplex ultrasound is crucial to make sure it's not developing into a pseudoaneurysm.
We'll get to pseudoaneurysms. But first, this retroperitoneal hematoma you mentioned, why is that one more dangerous?
Ah, yes. That's bleeding into the space behind the abdominal cavity.
Mm-hmm.
It's a much higher risk if the puncture is high in the groin, above a specific artery called the inferior epigastric.
Okay.
And it's more dangerous because there's less tissue back there to naturally compress the bleeding, less tamponade effect.
Yeah.
So the bleeding can be much more significant, even life-threatening.
Wow. And you said it's linked to worse outcomes.
It is.
Yeah.
Associated with higher morbidity, mortality, and cardiovascular events during the hospital stay. The really tricky part is that the signs can be subtle.
Not like an obvious bulge in the groin.
Not always. It's internal. So
Yeah.
you need a high index of suspicion.
What makes someone more prone to that specific type?
Risk factors include being male, being on anticoagulants, having a lower body surface area, and like we said, that higher femoral puncture site.
And the signs, if they are subtle, what should you look for?
Things like unexplained low blood pressure, sweating, maybe pain in the groin, abdomen, or even the back. Sometimes a slow heart rate, bradycardia. It's not always obvious, which is why an abdominopelvic CT is the go-to test if you suspect it.
Right. So if it is confirmed, what's the treatment? Always surgery.
Depends on how the patient is doing. If there are neurological problems in the leg, if they're hemodynamically unstable, losing blood, or in severe pain, then yes, intervention is needed.
And what kind of intervention?
Could be surgical decompression, opening up the groin, or an incision just above it to find the bleeder and repair the artery. Or sometimes endovascular options like covered stents can be used, especially if the injury is higher up. Just have to be careful not to cover the deep femoral artery origin.
Okay, shifting from bleeding for a moment. Another access complication is an AV fistula, an AVF. What's that?
That's an abnormal connection forming between the femoral artery and the nearby femoral vein. It's pretty rare, actually, less than 1% reported incidence.
Any reason why that might happen?
Factors associated with it include things like high heparin doses, being on warfarin, left-sided access seems slightly higher risk, high blood pressure, getting access in both the artery and vein at the same time, and being female.
Interesting. Do they always cause problems?
Not necessarily. One study found almost 40% closed on their own within a year, and often they don't cause any symptoms.
So how would you even find it then?
Usually during the physical exam, you might feel a vibration, that's the thrill, or hear a continuous whooshing sound with a stethoscope, the brute. Duplex ultrasound confirms it shows this specific blood flow pattern.
And if it doesn't close spontaneously and needs treatment?
Well, you could just watch it, especially if it's small and not causing issues like stealing blood flow from the leg or affecting the heart. Regular duplex checks are needed then.
Or active treatment?
Right, surgical repair is an option. Or, increasingly common, endovascular repair using stent grafts, little fabric-covered tubes, to basically seal off the connection from the inside. Ultrasound-guided compression isn't very successful, and thrombin injection carries risks here. It really comes down to the specific case.
Okay, let's tackle pseudoaneurysms now. You mentioned them earlier. What defines a PSA?
So, unlike a hematoma, which is just pooled blood outside the vessel, a pseudoaneurysm, or PSA, happens when the hole in the artery doesn't seal properly after the sheath comes out. Blood leaks out, but gets contained by the surrounding tissue, forming a sac.
But it's not a true aneurysm.
Correct. A true aneurysm involves all layers of the artery wall bulging out. A PSA is really just a contained leak. The key difference from a hematoma is that there's still active arterial blood flowing into the sac, usually through a distinct neck.
How often do these pop up?
Again, pretty low incidence these days, less than 1%. Often happens if compression after sheath removal wasn't adequate, maybe because of where the puncture was relative to the femoral head, making it hard to press effectively, or sometimes if a closure device fails.
Any specific risk factors or signs?
Yes, similar risk factors to hematomas. Older age, female sex, obesity, bigger sheaths, anticoagulation or antiplatelet meds, and using manual compression itself can be a risk factor compared to some devices.
In finding it?
On exam, you might feel that pulsating mass and hear a systolic brute, a whoosh, just during the heart's contraction phase. Duplex ultrasound is really the key diagnostic tool. You see the sac, the swirling flow inside, and that classic to and fro pattern in the neck. That's pathognomonic, really tells you what it is.
CT scan helpful here too.
Can be, yeah, especially if you're worried it's extending way back into the retroperitoneum.
So management, I imagine you don't want that pulsating sac hanging around. Surgery?
Historically, yes, especially for larger ones or ones that were expanding, because they could press on nerves, break down the skin, or bits could break off and travel downstream, distal embolization.
But now, more minimally invasive.
Definitely. There's a strong trend towards that. Ultrasound-guided compression is one option. Pressing directly on the neck of the PSA with the ultrasound probe to try and get it to clot off.
Does that work well?
Success rates are okay, maybe 60–90% in some series, but it can be difficult if the patient's on anticoagulants, if the PSA is large, or if it's just too uncomfortable for the patient to tolerate the pressure for long enough. And there are risks, rupture, embolization, even DVT.
Okay. What about thrombin injection? You mentioned that before too.
Right, ultrasound-guided thrombin injection. That's become a very common treatment. The idea is to inject thrombin, a clotting agent, directly into the PSA sac under ultrasound view.
And it just clots off.
Exactly, usually very quickly. It's technically an off-label use, but studies show it's generally more successful than compression.
Any downsides to thrombin?
There are risks. If the thrombin accidentally gets into the main artery or vein, it could cause a clot there. And very rarely allergic reactions, especially with older bovine preparations. Failure is more likely with larger PSAs, wider necks, or if the patient stays on anticoagulation. For really small, stable PSAs, just watching them might be okay too.
And when does surgery still come into play?
Definitely for the larger ones, or those with wide necks where thrombin might not work well, or if the minimally invasive options have failed. Surgery involves opening the area and directly repairing the hole in the artery. Endovascular options with covered stents are also used, especially after large bore access.
Okay, one more access site issue before we move up the body. Thrombosis. Clotting off the main artery itself.
Yeah, thrombosis of the common femoral artery, the CFA. It's a known complication, though fortunately not super common. Occlusion rates are low in modern studies.
How does that happen?
Even just simple compression after the procedure can sometimes lead to it, especially if there's already plaque atherosclerosis in the artery or if there's been prior surgery there.
And when would you realize that's happened?
Typically right after the sheath is out and you've finished holding pressure. The pulse might be gone, or the leg shows signs of ischemia,
And the fix for that.
Usually requires going back to the operating room. Groin exploration, maybe removing the clot, a thromboembolectomy, possibly cleaning out plaque, an endarterectomy, and putting a patch on the artery. Sometimes endovascular techniques like clot removal devices or clot-busting drugs can be used too.
All right, we've spent a good bit of time on the groin, which makes sense. It's the most common access. But procedures use arm access too, right? Axillary brachial arteries.
They do, yeah. Increasingly used as alternative access sites, especially for complex aneurysm repairs or interventions in the chest or neck.
Similar problems up there.
Similar categories, yes, but maybe different frequencies. For instance, brachial artery access seems to have a higher overall complication rate compared to femoral, more hematomas, more stenosis, or blockages at the site.
Interestingly, you mentioned surgeon experience wasn't a predictor.
Correct, at least in one large registry study.
What are the risk factors specific to the upper extremity?
Larger sheaths, definitely. Anything over 5 French. Using percutaneous access versus a small surgical cut down. And female gender pops up again as a risk factor. Nerve injury is also a bigger concern up there.
Nerve injury. Why more in the arm?
Just the anatomy. The nerves of the brachial plexus, especially the median nerve, run really close to the brachial artery in a tight compartment. So hematoma or direct injury during access is more likely to affect the nerve.
What would the patient feel?
Pain shooting down the arm, maybe weakness, numbness, tingling paresthesias. Often it's caused by a hematoma compressing the nerve.
And a treatment for that.
If it's compression, then surgical decompression, opening that fascial compartment to relieve the pressure and repairing the artery if needed. Vigilance is key because nerve damage can lead to permanent disability.
What about clotting off the brachial artery? Thrombosis.
Also a risk, maybe even higher risk than in the femoral, because the brachial artery is smaller. If the patient complains of hand pain, numbness, or tingling after brachial access, you need to get that sheath out quickly.
And closing it.
Careful manual compression, just enough pressure to stop the bleeding, but making sure you still have good blood flow to the hand. Check the pulse frequently.
Okay, and radial artery access. Through the wrist.
Yeah.
That seems really common now, especially in cardiology.
Hugely common. Cardiology, neurointerventional radiology have really adopted it. Vascular surgeons use it too, maybe more for kidney or intestinal artery work, sometimes iliacs. It's generally very safe.
But complications can still happen.
Oh, yes. Pseudoaneurysms, probably one of the more common ones, and sometimes those actually need open surgical repair. Radial artery occlusion clotting off also happens post-procedure.
Does that cause problems?
Yeah.
Losing the radial artery?
Often, surprisingly, no major clinical issues because the hand has excellent collateral blood flow from the ulnar artery. But things like higher heparin dose, shorter compression time, older age, female sex, bigger sheaths, and a smaller radial artery to begin with make occlusion more likely.
And briefly, what about pedal access? Going in through the foot?
Yeah, that's mainly for tackling blockages in the tibial arteries down in the calf that you just can't cross from the groin or the arm. You can either snare wire down from above or put a small sheath directly into one of the foot arteries.
Risks there.
Retrospective studies suggest pretty similar complication rates at the access site and the target vessel compared to traditional approaches. The bigger question mark is the long-term effect on that foot artery itself. Whether using it for access impacts future options.
Okay, let's switch gears to the tools used to close the access site. Vascular closure devices, VCDs. They're meant to avoid long manual compression rate.
It's exactly. Faster sealing, earlier ambulation, potentially discharge, less discomfort for the patient, and you can use them right away without waiting for anticoagulation to wear off completely.
And not everyone uses them.
No, adoption isn't universal. A big Cochrane analysis showed they definitely reduced time to hemostasis compared to manual compression and didn't seem to increase major complications like death or infection based on the data available then. But there's limited head-to-head data comparing different devices.
And they're used beyond just standard femoral access.
Yeah, increasingly for antegrade femoral punctures, going down the leg, and even for axillary artery access. They offer convenience, but like anything, they have their own potential complications.
Your notes mention several types: perclose, star-close, exoseal, angioseal, minx grip. Do they have unique issues?
They do, based on how they work. Perclose uses sutures. Failure can happen, maybe needing manual compression or another device or even open repair. Predictors for failure with large sheaths include obesity, heavy calcification, bigger sheaths. There's a whole technique for pre-closing before large devices like EVR grafts go in, leaving sutures ready to tie.
Right, star-close.
That deploys a metal clip, nitinol. Studies generally show similar major complication rates to manual compression, maybe fewer minor ones.
Exoseal.
That puts a bioabsorbable plug outside the artery. High success rate for stopping bleeding immediately, but sometimes deployment is tricky with scar tissue or calcification. Minor issues like PSA or hematoma can occur, generally well tolerated.
Angioseal.
That's a collagen plug device, also good for faster hemostasis and ambulation. But there's a known risk of ischemic complications blocking flow if it's deployed incorrectly inside the vessel lumen. Overall, major complication rates seem similar to others, though.
And mixed grip.
Uses a different type of plug, polyethylene glycol, also extravascular. Some registry data, however, suggested it might have a higher risk of overall vascular complications, bleeding, and transfusion compared to other VCDs. So, device choice matters.
So broadly, what are the main failure modes or complications with VCDs? Bleeding is still possible.
Oh yeah. Device failure leading to bleeding is probably the most common VCD complication, if the device just doesn't seal the hole properly.
What do you do then?
Depends on the device. With suture-based ones like Perclos, sometimes you can get a wire back through it, put a sheath back in, maybe try another closure device, or just buy time for anticoagulation to wear off and hold manual pressure. Protamine to reverse heparin is also an option. If you can't salvage wire access, it's immediate manual compression.
And the other category, ischemia, blocking blood flow.
Less common, but definitely more serious. Can cause immediate limb ischemia or delayed symptoms like claudication or rest pain. That's why checking pulses before and after is so crucial.
How do the devices cause that?
Depends on the type. Suture devices could potentially create a flap inside the artery or cause it to clot off. Plug-based devices, if deployed incorrectly, could embolize downstream or cause a local clot right at the puncture site.
And treatment for ischemic complications.
Usually requires urgent surgical intervention, opening the groin, removing the device or clot, repairing the artery, sometimes even bypass.
Okay, we've covered access and closure pretty thoroughly. Let's talk about complications related to the procedures themselves, the balloons, stents, wires. Starting with dissection during angioplasty. That's a tear in the artery wall.
Exactly. When you inflate a balloon to open a blockage, you're intentionally disrupting the plaque and stretching the artery. Sometimes this causes a tear or dissection in the inner layers.
And that's bad because
That flap of torn tissue can block blood flow, or the dissection can propagate further down the artery, potentially leading to occlusion. You see it on the angiogram as a line or flap within the vessel lumen.
how do you manage that?
Initial step is often prolonged, low-pressure balloon inflation right over the dissection, trying to essentially tack the flap back against the wall.
And if that doesn't work?
If the dissection is significant, causing a major narrowing or limiting flow, then usually a stent is placed, either self-expanding or balloon expandable. The stent acts like a scaffold to hold the flap down and keep the artery open. Sometimes, for focal dissections below the groin, directional atherectomy can be used to basically excise the flap.
What if you suspect the wire itself has gone under the plaque layer, subintimal?
Yeah, if you feel resistance or can't get blood back through the catheter, you stop. Contrast injection will usually show the dye stagnating outside the true lumen. You need to recognize that before deploying balloons or stents there. Small dissections in otherwise normal arteries, especially larger ones like the iliacs, might be okay if they're not flow limiting, but significant iatrogenic dissections generally need treatment.
You mentioned subintimal angioplasty earlier, though. Sometimes you want to be in that space.
Correct. For chronic total occlusions, intentionally creating that dissection plane and advancing the wire in the subintimal space is a technique to bypass the blockage. The absolute key is knowing exactly where the artery opens up again distally and getting the wire back into the true lumen there, sometimes using special reentry devices. Done carefully, it's effective.
Okay, moving to another potentially nasty one, embolization. Bits breaking off and traveling downstream.
Yeah, that could be devastating. Plaque or clot gets dislodged by the wires or catheters, especially in really diseased or aneurysmal arteries or during complex aortic work.
And the consequence depends on where it goes.
Exactly. If it showers down into the run-off vessels of the leg, you can trash the foot, turning a claudication case into a limb salvage emergency. If it happens in the aortic arch, it can cause a stroke.
How common is that?
Clinically significant embolization rates aren't super high, but it definitely happens. Atherectomy devices are sometimes associated with a higher risk, as are procedures on lesions with a lot of thrombus.
Prevention and
Yeah.
rescue.
Prevention involves recognizing high-risk situations on imaging, good anticoagulation, careful technique, minimizing manipulation. Sometimes embolic protection devices, little filters or baskets on wires are used, especially if there's heavy plaque or clot burden or critical single-vessel runoff.
If it happens anyway.
Rescue involves more heparin than trying to suck the clot out with aspiration catheters or using mechanical embolectomy devices. Thrombolytics might be used as well. If endorescue fails and the limb is acutely threatened, open surgery to remove the emboli is necessary.
What about perforations? Let's start with just the wire poking through.
Simple wire perforations, especially small ones in the leg arteries, often seal themselves off. Just need conservative management. Watch carefully. Stiffer wires are more likely to do this, so maybe avoid them as the first wire in diseased vessels.
How do you know it happened?
You might see the wire tip outside the artery contour on fluoro, or it curls abnormally. After pulling the wire back, a puff of contrast might show a small leak. The key is recognizing it before advancing bigger devices over that wire into the extravascular space.
And perforations from balloons. Angioplasty.
That's generally more serious. Can cause significant, even life-threatening bleeding, especially if you overdistend a heavily calcified, non-compliant vessel. Iliac artery perforations can lead to massive retroperitoneal hemorrhage.
Diagnosis and management.
Angiography clearly shows contrast extravasation, leaking out. Immediate step is to inflate a balloon, usually a large, compliant one, gently across the perforation site to tamponade the bleeding.
And then?
Definitive repair options include covered stents, if feasible. Sometimes open surgical repair is needed, especially for complex iliac perforations. If endovascular repair isn't immediately possible, you can actually leave that occlusion balloon inflated while prepping for open surgery. Perforations below the groin during angioplasty are less likely to be life-threatening, but can cause PSAs or occlusions later.
And atherectomy devices, can they perforate too?
Yes, if the device cuts too deep or is oversized, it's rare, less than 1%. Risk factors include oversizing, using it near bifurcations, careful technique, orthogonal imaging, sometimes IVUS helps prevent it. Multiple passes can also thin the wall, increasing risk of AV fistula or PSA later.
An AV fistula caused by atherectomy.
Yeah, you might see rapid filling of a nearby vein on angiography. Often, small ones in the SFA aren't clinically significant and thrombose on their own. If symptomatic, initial treatment is prolonged balloon inflation. If that fails, maybe reverse anticoagulation, then consider a covered stent. Surgery is the last resort if ischemia worsens.
Let's talk specifically about EVER access. Those big sheaths must cause unique problems.
They certainly can. Delivering those large stent grafts, 1824 French sometimes, requires good access vessels. Pre-op planning with CT scans is crucial to assess iliac size, tortuosity, calcification.
But problems can still happen.
Absolutely. Despite planning, you can still encounter issues. Arterial rupture, most commonly the common iliac artery, is a known risk. Can cause profound hypotension, often repairable endovascularly with covered stents, but sometimes requires open surgery and carries mortality risk. Seems more common in women during TEVAR procedures.
So, surgeons are sometimes using conduits now?
Yes, there's an evolving lower threshold to surgically place a conduit, basically sewing a tube onto the iliac or femoral artery to provide safer access for the large device, although that adds its own surgical morbidity.
But rupture can still happen even with conduits.
It can. Operators need to be ready with occlusion balloons and covered stents. Often, the rupture isn't apparent until the large sheath is removed, because the sheath itself is plugging the hole.
So removing the sheath is a critical moment.
Extremely critical. You must maintain wire access across that area until you're sure the patient is hemodynamically stable after sheath removal. Allows you to quickly put up an occlusion balloon if needed. There's the dreaded iliac artery on a stick scenario where the inner lining gets stripped out with the sheath.
Oh, wow. And definitive treatment for rupture.
Usually involves placing multiple overlapping covered stents to span the entire injured area. But again, sometimes open surgical repair is still required.
That really underscores the need for preparation. Okay, we're nearing the end, but let's touch on a few other important complication categories. Thrombolytic therapy, clot-busting drugs.
Right, used for DVT, acute limb ischemia, PE sometimes. The main risk there is bleeding. Access site hematoma is most common, but serious bleeding like intracranial or GI hemorrhage can occur, though rates are relatively low in major trials.
Management.
Careful monitoring of blood counts, coagulation status. Lower lytic doses might reduce risk. Significant bleeding means stopping the infusion. Any change in mental status requires stopping immediately and getting brain imaging due to the risk of brain bleed.
Device infection. Stents or grafts getting infected.
Rare, thankfully, for both stent grafts, EVAR-TEVAR, and bare metal stents in the peripheral circulation, but devastating when it happens. Incidence is low, maybe 0.51% for grafts. Hard to pinpoint exact causes, breaks in sterile technique, prolonged procedures, maybe bacteremia from another source.
Diagnosis and treatment.
Diagnosis is often one of exclusion after ruling out other infection sources. PTDC can be helpful. Treatment is very aggressive. Removal of the infected device and all surrounding infected tissue followed by bypass, preferably with the patient's own vein, autogenous conduit, or an extra anatomic route to avoid the infected field. Staph aureus is the usual culprit.
What about devices breaking or moving?
Yeah, wires, catheters, even stents can fracture or embolize. Fragments need to be retrieved promptly, usually with endovascular snares or biopsy forceps, to prevent them causing clots or traveling further. Stents can migrate if not sized correctly or get displaced during passage of other equipment. Careful technique is needed, like advancing balloon expandable stents through tight spots still within their delivery sheath.
And complications specific to venous procedures, like stenting veins.
Venous angioplasty and stenting are common, especially for central venous stenosis in dialysis patients. Vein rupture can happen with aggressive ballooning, but often sealed spontaneously with pressure due to the low-pressure system. Stent migration is reported, though. Iliac vein stents, SVC stents, even renal vein stents for nutcracker syndrome, potentially embolizing to the heart or lungs. Retrieval usually involves snares, sometimes surgery.
IVC filters, preventing clots going to the lungs.
Placement complications are rare. It's the late complications that cause more trouble. Filter embolization to the heart, struts penetrating the vena cava wall, sometimes into adjacent organs like the duodenum or aorta, or the filter itself clotting off thrombosis, causing leg swelling. Filter fracture and strut embolization are also concerns, especially arguing for retrievable filters in younger patients.
And lastly, any specific considerations related to COVID-19?
Just that the hypercoagulable state seen in some COVID patients might increase the risk of clots forming during or after procedures. Also, anecdotally, with more lines being placed sometimes by non-traditional teams during surges, there might have been an uptick in iatrogenic injuries needing repair.
Wow. Okay, that was a very comprehensive deep dive into the local complications. It really paints a picture that even these minimally invasive procedures have a whole range of potential issues.
They absolutely do. From the fairly common things like groin hematomas, right through to rare but very serious events like graft infections or iliac ruptures. Understanding this spectrum is critical.
So for you listening, hopefully this gives you that richer, more nuanced understanding of what's involved, going beyond just the surface level benefits. It highlights the complexity and the skill involved in managing these situations when they arise.
And it leaves us with something to think about, doesn't it? As these endovascular technologies continue to advance new devices, new techniques, how will our understanding and our ability to prevent and manage these local complications evolve alongside them? Or perhaps, thinking about that constant balance between less invasion and potential risk, what are the truly crucial factors we need to weigh, as clinicians and patients, when making decisions about vascular treatments? That interplay between innovation and risk is always going to be there.